Hi, welcome everyone. My name is Shabir Musa. I am a family physician in Soweto, Johannesburg. I'm facilitating this webinar. It is an effort by Wonka Africa, the Afro-PHC, as well as WHO to try and bring together people on the ground in family medicine, primary health care across the continent to look at different responses from the primary health care setting to the COVID pandemic. So with us for the focus in South Africa, we have Dr. Waasila Jassat, who works with the NICD as a consultant at the moment and providing an invaluable service to them in terms of analyzing data on hospital surveillance. So before we go, let me perhaps just start by briefing people on the way the platform works. Essentially, you have the screen in front of you. If you just hover over it, you should be able to see the settings above, which are available. You can then just look for the audio settings and get that fixed up if it's a problem. You can also add questions to Q&A. So please make inputs into that and use that as the way to send questions through to us. You can also use the chat on the right-hand side. You'll see that pop up. And just, if you want to add some chat in between. You can also raise your hands if you wish to speak. And we leave that for last. So with that, I want to just share with you what's going on broadly at the African continent as of today. As you can see that there are almost 1 million cases of COVID in Africa. The curve's moving up, but in fact tending to level off, and the rate of increase might be decreasing as we see in South Africa. That as South Africa is going, it sort of had this very different kink in its curve, but has persisted in rising, surpassing places like the United Kingdom and Africa and Italy. It's now the 5th largest country by size of COVID infections. As you can see from the African set, that it leads the pack, mostly exceeding Nigeria at the moment. And what's interesting is the Nigerian curves also beginning to tail off. So if you're looking at South Africa particularly, it seems like daily infections seem to have curved downwards. And I think that's being felt on the ground by clinicians, both in primary care and at the hospital. And I think this is perhaps not showing up in terms of deaths, but I think the impression at hospital level is certainly that there's some sort of tailing happening. You can see that this is across the country, and in fact in some of the provinces, except in Mpumalanga, where it's still on a persistent increase in Northern Cape. So it seems to be riding out in South Africa. Certainly the number of deaths have been not as reported, almost 3 to 4 times more than the reported deaths are the deaths based on the excess deaths in the National Population Register. And I think you can see that how it varies by province and varying by different big cities. And you can see that even that deaths, those deaths have somehow dropped off in the last few days and a week or so. Thank you very much. I think this is basically a webinar to try and look at what's going on the ground in more specific than what I presented. So I want to really appreciate Dr. Jassat for sharing that. Waasila, over to you. Thank you very much for joining us, and thanks to all the participants who've joined us. I hope you find that what Waasila has to share quite interesting. Waasila,
Hi, colleagues, and thank you for the opportunity to be with you today and to share with you a little about what we're doing at the NICD. So at the NICD in March, Prof Lucille Blumberg realized the need to look at hospital admissions for COVID-19 in South Africa. And so we set up this online platform to collect information at sentinel sites around the country. And the purpose was really twofold, to describe the epidemiology of the outbreak so we could inform policy decisions around control measures in specific groups of the population. And secondly, in terms of supporting the program, to describe the distribution of hospital admissions by province, the type of facility and health sector, and also where the settings of care were and the requirements for oxygen and ventilation, so that we could anticipate resource demands and plan for resource allocation. So the variables that are collected on the Sentinel Hospital Surveillance System are drawn from the WHO case reporting tool. And so there are demographic information about comorbidities, complications that may have developed, medical treatment as well as medical interventions, the setting of care and outcomes. So in South Africa, there are, in the public sector, there are no uniform electronic information systems. The Western Cape has an information system, but the other provinces do not. In the private sector, many of the private hospital groups have their own independent electronic information systems. So what the NICD did was develop an online platform that allows for capture of patient information on a cell phone, tablet, or a computer. So currently 54 public hospitals and 43 private hospitals enter data onto those digital forms. But the system is quite flexible, and we also allow for bulk uploads where these already exist, because we don't want to duplicate data collection sort of efforts. And so all Western Cape public hospitals submit data by an Excel export every day, and 6 private hospital groups do the same. So this data is all merged within our digital platform, and it's stored in the Department of Health's Azure database. So this is the user interface on the online platform. So a hospital user is able to register and then submit information on patients, on their admissions, do a daily assessment, and then do a discharge on outcome. They are also able to view statistics for their hospital, which is updated daily. And they are also able to draw a line list for their hospital that will go to their email. I think it was always important for us that this data wasn't submitted out, to third parties, and that the hospital wasn't able to also view their own patient information. So there are a variety of reports that we create. Every day we share a daily report, which is a summary across the country and across each province of all admissions and deaths that are recorded. We share a line list every day to each province and to the National Department of Health of all the admissions. We also share these daily reports on the NICD website, where there is also an interactive dashboard. We produce weekly reports where we describe admission trends and analyze risk factors for mortality, and this is available on the NICD website as well. We also share data with the National Institute for Occupational Health, and they use this information to produce a weekly report on healthcare workers admitted with COVID-19. There have also been a couple of publications and reports, one describing the surveillance program, and the second that describes admissions in pediatric population. So I'll share with you the progress in implementation, because while we started as a Sentinel Hospital Surveillance System, we very quickly got interest and traction across all provinces and in the private sector. So currently we have on the database about 45,000 admissions from 340 hospitals around the country. So this table shows you the coverage in each province. We have 109 public hospitals reporting and 231 private hospitals reporting, but it varies from full coverage in the Western Cape, because we get all their public and private sector data, to very low, no coverage in Mpumalanga's public sector. And just to share with you, a decision has been taken by the National Health Council that DATCOV will be rolled out to all public sector hospitals. So we're already working with provinces, and more hospitals are coming on board quite quickly. So I thought I'll share some of the data that has been generated from this platform. So this is an epidemiological curve of admissions by public and private sector from the beginning of the epidemic. You'll see that there were more admissions earlier on in the public sector, which is when the epidemic was concentrated in the Western Cape. But since about week 25, more admissions have been in the private sector. But this also reflects underreporting in the public sector. This shows you a cumulative graph of admissions across each province. You will see the earlier surge in the Western Cape in blue, and the sort of leveling off of admissions in the Western Cape. You'll see a later surge in Gauteng, in KZN, and in the Eastern Cape, And indications are also that the rate of increase of admissions has dropped. This is admissions by age and gender, and you will see that most admissions happen in the sort of working age between 30 to 69, and you'll see also that more admissions occur in females. These are the outcomes for the 44,000 admissions that we have reported. 69% were either discharged alive or transferred out to other hospitals. 15% had died, and 16% are currently in hospital. So the case fatality ratio is calculated for only those admissions with an outcome, so those who had died or discharged. So the case fatality ratio for roughly 36,000 admissions was 18%. This is an epi curve of deaths in the public and private sector. And this is the cumulative deaths across each province. And you will see a leveling off in the Western Cape. And this is the distribution of deaths by age and gender, and you'll see the difference from the admissions curve where deaths are more frequent in older ages and deaths are also more frequent in males. I'll quickly share with you the multivariable analysis of factors associated with mortality. I'm not sure if this is very clear, but what you can see is the significant association with a higher risk of association for males with increasing age in the black, colored, and Indian race groups. And then in terms of comorbidity, there's an increased risk, a modest risk for hypertension and for cardiac disease, but a greater effect for diabetes, chronic kidney disease, and cancers. There's also a risk associated with active TB and patients who have active and past TB. And there's also a risk associated with HIV. We also see associations for patients who are admitted in the public sector and for patients admitted in the Eastern Cape, Gauteng, and Northwest provinces, with a lower risk of mortality in Mpumalanga. And there's a tendency to a higher case fatality ratio as each month progresses of the epidemic. I want to share a little bit about comorbidities. So in patients who had information about comorbidities, the most frequently reported were hypertension and diabetes. We also had about 3,200 patients with HIV, and then 640 patients with active TB, and over 1,000 patients with previous history of TB. This is the case fatality ratio by 5-year age bands, and you will see a nice increase of case fatality ratio with each increase in age. And you will see that the increase is higher for patients with comorbid disease than those with no comorbid disease. This is the presence or frequency of comorbid diseases across each age group. So you'll see in orange and gray that hypertension and diabetes seem to be the most frequently associated with mortality in the older age groups, but in the younger age groups, HIV and obesity and TB also play a part. I wanted to also look at diabetics because we know from other countries and we know from the data that the Western Cape has reported that diabetics have been at increased risk for mortality. So for all diabetics, the case fatality ratio is about 28%, and this increases particularly for patients who have past tuberculosis, malignancy, chronic kidney disease, and obesity. And in fact, if a patient was admitted with diabetes and obesity, 55% of them died in hospital. You'll also see the increase in case fatality ratio for a patient compared to those with diabetes only, those that had other comorbid disease, one other or more than two other comorbid disease had higher case fatality ratios. I thought this was also interesting to share. This looks at the number of comorbidities across the different age groups. And so, as you would expect, that patients with one or more, two or more comorbidities have a higher case fatality ratio. But I think what's also worth noticing in this table is that there are even young people with no comorbidities that are reported by the hospitals that have died. I'll share a little bit of health services trends. So in South Africa, most admissions have been in district hospitals, and this is in the public sector, followed by the national central hospitals, then regional hospitals, and then provincial tertiary hospitals. But when you look at the case fatality ratios, they were highest, as you would expect, in the referral centers. So the tertiary, regional, and central hospitals had the highest case fatality ratios. But of concern is a case fatality ratio of 23% in district hospitals, where there may not be facilities for intensive care and ventilation, and where you would expect that there are referral pathways to refer patients to higher levels of care if required. This is data not out of DATCOV, but out of other systems. So I wanted to show you a little bit about excess deaths and out-of-hospital deaths. So the Minister's line list of deaths on the 31st of July reported 451 out of the 7,751 deaths that had occurred in the community or at home. And this equates to 6% of all deaths that were reported to the National Department of Health. And then the South African Medical Research Council releases a weekly report of excess deaths compared to historical trends in the same time period. And the report of 28th July shows that there's an excess of almost 30,000 deaths from natural causes for persons 1 year and older compared to similar time periods in previous years. And I show this graph because we do know that the deaths that we are reporting is probably underreported, and there are excess deaths, and that we do know that a significant proportion of deaths are occurring outside of hospitals. I also thought I'll share with you some surveillance in long-term care facilities. So our hospital surveillance system was expanded to be implemented in nursing homes, rehabilitation homes, frail care centers, and mental health facilities. So it's just been piloted, and in 15 long-term care facilities in 7 provinces of South Africa, we picked up 407 positive cases in residents and 271 positive cases in staff. Currently 181 are active cases, 451 have recovered, and 46 people died in these 15 long-term care facilities. So I thought I'll end on a few points. So number one, the factors that we found that are associated with mortality, which are older age, male sex, multimorbidity, and comorbidities, particularly hypertension, diabetes, chronic cardiac disease, chronic renal disease, and malignancy, have been reported in other countries, and the risk of HIV and TB have been reported in the Western Cape data. So I think that this HIV and TB associations are important. I think what's also important in the data is the number of pediatric admissions and deaths that we've had. Currently, 3% of all admissions have been in individuals 18 years and under, and we have reported 32 deaths in the pediatric population, although it must be said that most deaths have occurred in children with serious comorbidities like cancers, cardiac disease, and sort of multiple underlying conditions. And also important is deaths in young people who have no comorbidities that needs further investigation. So data is not available or not complete to be able to answer all of these questions, but in terms of obesity, where it was recorded in 983 patients with outcomes, 414 had died. So 42% of those who were recorded to be obese had died. And we know in other countries that obesity has been reported as a significant risk factor for mortality. Our data isn't able to distinguish between newly diagnosed versus pre-existing conditions like diabetes, and also isn't able to distinguish between the level of control, for instance, through HbA1c for diabetes. We also are currently looking at viral suppression and CD4 for HIV to be able to characterize the risk in HIV between those that are virally suppressed and those that are not, or those that are on ART and are not, and we'll be releasing some of that data soon. And our data also doesn't characterize the risk in older people versus whether they, in terms of their wellness or frailty scores. And I know that Discovery Health data is able to do that and has shown that amongst older people, those that had a lower score for wellness had poorer outcomes. The other thing our data is showing is information to track the epidemic progression. So what we're seeing is a possible plateau in admissions in one province and a lower rate of increase in admissions in a few other provinces. And this confirms the trends that we see with cases. And we know that when local transmission is widespread and testing strategies change, then hospital admission surveillance and mortality surveillance provides a more reliable picture than the case numbers. I think the other thing worth noting are the health services trends that I've shared. There is a variation in case fatality ratio between the public and private health sector, between different provinces, between the types of health facility and also the month of epidemic. And there are a number of deaths that are happening outside of hospital. And I think what this points to is the need for clinical governance and support for quality of care in some of our provinces and some of the facilities. We need to look at referral pathways specifically from district hospitals to higher levels of care. We need to look at home management of patients so that we can identify those that need referral and further care. And like the Western Cape have done, possibly consider proactive care for those at high risk. So for instance, the Western Cape have admitted diabetics at high risk in the intermediate care sort of field hospitals, and they've monitored them. And as soon as they show indicators of deterioration, they have transferred them to the central hospitals for treatment. So I think the value of the surveillance system is that it provides real-time data, and we share summary reports daily and detailed analysis weekly. This data is able to address a knowledge gap. So many publications have been shared about the profile of COVID-19 in high-income countries, but there are still many unknowns in low and middle-income countries, and particularly in the South African setting, where we have a very different population structure and where we have colliding epidemics of non-communicable diseases, obesity, and infectious diseases like HIV and TB. So I think we are very interested to use the surveillance platform to address important questions in terms of data for action. So the data must be able to characterize which people are most at risk for poor outcomes. It should inform what guidelines we should have for patients with non-communicable diseases and HIV and TB. What guidelines should we have for managing COVID-19 in these high-risk groups? And where should our resources be targeted to support provinces or facilities that may be struggling? Of course, there are limitations with sentinel surveillance. We don't include all hospitals, and as I showed you earlier, the coverage in some provinces of public hospitals is still quite poor. So this data may not be truly representative of all hospital admissions throughout the country. But on comparison with the number of deaths reported, we find consistently that the DATCOV coverage is around 80 to 85%. Because we capture information from most of the large hospitals and the designated hospitals for COVID-19, we are reasonably comfortable that we capture most admissions in the country. Another limitation is that we only report hospital-based admissions and deaths, so our system does not include deaths that occur outside of hospital, except for the small surveillance that we now have running in the long-term care facilities, which we hope to expand as well. And finally, data quality is, of course, dependent on the information being submitted to us by the healthcare institutions. So it's not possible for us to verify or check the quality of all the data, but we do have built-in data quality checks, and we do have some triangulation with other data sources. We extract information from the master line list of cases, from the notifiable medical conditions, from the medical schemes data as well, where it's missing in our database. And we have also been triangulating our deaths with deaths reported by provinces to the Department of Health, and also with deaths reported through the death notification by the Department of Home Affairs to the MRC. And so we provide them with a list of our deaths, and they compare against that to see that we have consistency in reporting. I'm happy to share the presentation and urge you to contact us if you need more information, and also to visit the NICD website where you can access some of these reports. Thank you.
Well, thank you very much, Waasila. That was a very useful insight into what's going on in hospitals. Well, I'm very impressed at the fact that such information is available, and it's a great thing that you guys have actually been able to put that together. I think there's certainly some insights that have come through that confirm what's happening globally, with diabetes being particularly an issue. I would ask some questions, but let me start with some of the questions that have come through. Ahmed Kaji has asked, why is there discrepancy between test statistics and test positivity rates between the NHLS figures released by the Department of Health? I don't know whether you can...
Yeah, so I've been working on the hospital surveillance and not really on the testing. As far as I understand, there are some, time lags in terms of, validating data that's submitted by laboratories and also deduplicating. But I understand that these systems have been streamlined as much as possible. I understand that the data is shared with provinces, and so that the data that's reported from NICD that's reported by the minister should be consistent with what's reported by the provinces. But I know provinces have their own processes of validation of their data. So I'm sorry that I can't really offer more, but I don't really deal much with the testing and case information at NICD. Some of my other colleagues might be able to answer on that.
Yeah, no, but I think those are valid comments. I think the whole system is very much dependent on the reporting that occurs as it proceeds, and it's completely outside of this sentinel data collection. But Abid Kaji asks another question, which I'm not sure you'll be able to answer as well. He asks, is it true that there is a higher fatality rate in the Muslim community compared to the rest of the country? I doubt you're collecting information like that, but nonetheless, maybe you have an answer. If not, we'll leave it at that.
Okay, so unofficially, I have, out of interest, been looking at the Muslim stats data because they are reporting a 9% mortality rate of Muslims in South Africa, whereas the population is at just under 2%. I mean, we are seeing that there's a higher risk in Indians, coloreds, and blacks, so that is a possibility. And I have tried to do some verification, and I also, in our data, am seeing an increased risk in the Muslim population. And I would put that down to a number of factors. I mean, I think that there are high risks or high rates of diabetes, obesity, high cholesterol, and so the diseases that we know are associated with poor COVID outcomes. Also, there are, the family structures in these homes may predispose to older people more likely to get infected, and possibly that's another reason for higher rates of death. But yeah, I mean, those are just my own observations. But I think there is something there.
Yeah, for sure. For sure. I think some of the questions I thought I'd ask as well. You've mentioned, obesity as being a sort of high risk associated as well. Does it fit in with the international scenario? I mean, lots of people in the globe tended to think in South Africa we would see a lot more poorer outcomes with HIV, TB, which you've picked up, but not quite as high as expected. But also obesity has popped up as being a feature in what you've presented. What is the comparison internationally in terms of obesity and then HIV, TB?
So I think with HIV, there were small case series in other countries, and there weren't, wasn't evidence for increased risk. But the Western Cape data that was published last month shows that there is a significant effect, and that effect was true whether the patient was on ART or not, and whether they were virally suppressed or not. I think our data is confirming that as well. With regards to obesity, the data is really difficult to interpret, and that's why it wasn't even included in the multivariable analysis, because it's difficult for the hospitals to report BMI. They don't collect weight and height. In some places they don't have a scale, or they can't get an ICU patient up to check their height. So we've asked for mid-upper arm circumference as well, but these things are not well completed. So what we are relying on is the subjective opinion of the treating doctor, whether the patient is obese or not. And it's not well completed, so we know in many cases where there is obesity, we don't know if a patient is not obese. So it's difficult to put that into a model because we have obese, yes, and unknown, and we don't really know the ones that are not obese. So that's one of the problems, is the way the data is collected. But the signal is definitely there, that there is an association, and I think other countries have consistently shown that there were poorer outcomes in patients that are obese. And just anecdotally, the doctors in the hospital are saying to us the sick ones are all, kind of overweight and obese.
You've also mentioned the case fatality at about 18%, and we've got underreporting going on. Where do you think we sit in compared to the rest of the world in terms of case fatality?
Yeah, I'm not sure. I've been trying to look at the case fatality ratios for in-hospital, outcomes, and it's difficult. It's difficult to extract, and we are preparing a publication, and hopefully we'll report on that soon. The case fatality ratio across all cases, I think, from what's reported, South Africa has a lower case fatality ratio than many other countries. But I think it would be interesting to compare in-hospital mortality, and hopefully we'll be able to report on that soon.
Yeah. You also mentioned that the staff in long-term facilities were infected. I noticed that the ratio is very high. Is that not a case of exactly what you talked about? You know, this kind of data ought to have some impact. What's going on in these small, you know, old age homes and the like,
Yeah,
that
I mean,
staff are
from what
so infected compared to people?
Yeah, we looked at the denominators, and so it seems like 8% in those 15 facilities, 8% of staff in total were infected, and 8% were residents as well. And the facilities are saying it's mostly staff bringing it in, so it's community acquired from the staff, and they bring it in, and then there are outbreaks within the long-term care facilities. And they are really struggling. Most of them have reported that they don't have many resources to even isolate well. They don't have enough PPE. They struggle to get support from the provinces in terms of managing these outbreaks. So I think it's something that we anticipated because we saw countries dealing with this early on in the epidemic. And yet I'm not sure that our long-term care facilities were fully prepared. We've just written a publication that will go into the SAMJ early next week to share some of this data and recommendations we make around focusing on infection prevention and control in these settings.
Mm. I mean, this question comes up immediately. What is government doing with the information you're providing? You mentioned that they're bringing more hospitals on board, but are they actually translating your findings into something meaningful in terms of action on the ground? I mean, you've mentioned one of these homes, nothing seems to be easy to do or being done. Is this translating anywhere else? Is it somewhere else that value is being added as an implementation value?
Well, I mean, I'm worried about that because I think sometimes it feels like we're just pushing numbers. We're reporting to provinces and to national the patient line lists, and so that those numbers are being reported and they're being shared. And I'm not sure how that's translated into action. So I've been, Prof Lucille and I are really keen that this information is translated into more than just, scientific reports of and p-values. And so we've been trying to look at getting it into the media, so sharing particularly the risk for poor outcomes with comorbidities and older age. And I think that the media has covered that sufficiently well. I think we're trying to look at particularly the risk. Next thing we're interested to look at is why are there high case fatality ratios in some hospitals, in some settings. And so the Rural Doctors Association is assisting with developing some webinars and have some clinicians that are going to be doing some training for those hospitals where we found a higher case fatality ratio. We are sharing we're partnering with the Department of Health and Department of Social Development at a national level on the care home surveillance. And so the partners that are helping to support those care homes, so Right to Care, I know, is one of the partners that have provided some resources to assist. So I'm hoping that providing the evidence to say there are these outbreaks will translate into mobilizing action from both departments and from the partners who have committed to assist, so that those care homes can be assisted. And I think to forums like this because I think the information needs to go out to GPs, to provincial clinical governance committees. The important thing to answer is why are deaths happening at home? Why are those patients not receiving care? Why are deaths happening in district hospitals? Do they need better referral pathways or more resources? So, I mean, I think that really it's at the province that I'm hoping that this information lands and that we can have some real interrogation of what this data is showing rather than just chasing coverage of facilities and coverage of people reporting. So, yeah, I mean, I think this is a point close to my heart and something that if all of you, have any thoughts about, we're willing to hear.
Well, that sounds like a useful invitation. I hope that people on the conference, the teleconference, the Zoom call, could actually share in the chat section what they think they could use from the information that Waasila's provided. What do you think you're going to be able to change or do using the information that's just been provided? So if you don't mind just adding into the chat section some thoughts to share, I think Waasila and I will both appreciate it. So feel free to put some thoughts down. You've mentioned, I think, these questions of what can be done. Is the platform open to home management settings? Like you mentioned long-term care facilities, but what about GPs who are beginning in some parts of urban Joburg, setting up these oxygen management centers, you know, at home and in sort of their own non-hospital settings? Would that data be, would they be able to provide you data?
I think we're
Link it up?
focusing on hospital admissions in like
All right.
established facilities, including field hospitals, and it's covering like lab confirmed COVID cases. So at the moment, I think we wouldn't cover those that are being managed at home by GPs.
Okay.
But I mean, I think that that's useful to you know, if we had some way of following the outcomes for those patients, how many of them require admission, I think
Yeah.
would be interesting to know.
It could be part of that long-term facility, you know, that non-hospital type of environment. But anyway,
The other
interesting.
things Yeah, the
Yeah,
other
go ahead.
things we've added is we collaborating with the Critical Care Society, and they've developed a format, a module that's hosted on our platform to collect information about the really sick patients being treated in ICU. And we're now in conversation with the MRC, who are coordinating pediatricians around the country who would like to create a pediatric registry. And so I think that registry will also be hosted in our platform, since we already have the information reported from the hospitals. So I think we'll be able to start tracking the sort of severity of cases in the pediatric population and providing evidence in a bit more depth. And particularly because we have had so many deaths, to be able to understand, you know, which patients die. And also to be able to report on the multi-system inflammatory syndrome, which we have had many reports of in South Africa. And I think that this platform will be able to soon provide evidence around that as well.
Um, I think Vanessa Governor asks, have you been able to pick up on post-mortem reports? Why are you collecting any data on that sort of score?
Yeah, so the NICD, I think today will have on their website the SOP and sort of protocol around post-mortem testing. And I think the minister announced this week that people with, you know, deaths at home that were clinically suspicious should have post-mortem swabs. And so there's a form that details which patients should have them and what the procedure should be. So it started in any significant way, but I'm hoping that to certify patients who die at home or in hospital that have not got a COVID confirmed diagnosis will soon submit post-mortem swabs as well, so we can look at that.
You've talked about, you know, I'm just trying to think of the value to the audience, which I'm assuming mostly from primary care. You've talked about the referral pathways being figured out. At the moment in Johannesburg, we've been trying to look at how the sort of field hospital works, and it somewhat differs from the Cape situation, where we found that it isn't well staffed. In fact, it's being run by volunteers at the moment, despite high level, you know, need to get it happening. There are not that many patients, especially because the hospital's admissions have tended to tail off in the last week or so. When we sat together around the table with, you know, the big departments, medical, you know, the physician, internal medicine departments, and field hospital and clinics, the two things that we came up with was, how do we actually get patients having access to hospitals and being better assessed there? Patients who are in the hospital who have been, who seem to be on the path to recovery and not needing really much more care except oxygen, could be then down referred to Nasrec as a field hospital, where they might be able to free up a bed but be managed in a relatively an intermediate care environment. And in fact, when we've looked at that, we've been very careful to say, let's not admit patients into this because of the difficulty of you know, capacity at the field hospital. But one of the key things that came up was what you suggested, looking at these patients who are intermediate risk and whether they admit them or not. And it's just been very challenging to actually consider that because of simple things that don't work in the field hospital in Nasrec. So I think that's just to give you some insight. I hope you're getting information from NASREC. I don't know whether that's on your radar, but I will try after this, try and link you up with people at NASREC so that they could perhaps feed that information in. Have you found this translating into any guideline resource changes in at any point? You've mentioned a couple of things, like webinars and the like. Any other high-level decision-making that's come out that you're aware of in terms of COVID management in the country from this data?
Well, I think the Western Cape released guidelines around testing in diabetics and around management of diabetics, recognizing the higher risk. But I haven't seen that in other provinces and not from a national level. But I have been engaging with the Non-Communicable Diseases Directorate at the National Department of Health, and we will be presenting to the IMT next week similar particularly around the non-communicable disease risk. And so, we hope that there will be some action arising out of that. But no, I think a lot is known. A lot is known from other countries, and so people understand the risks. And I think probably in hospitals and within clinician groups, there are protocols that take into account those that are high risk. I think the HIV and TB were recognized as new risk, and I'm not sure how that is translated into protocols around managing patients with HIV and TB and referring them or testing them. We keep knocking on the doors and we keep sharing the data. And I must say that we've got provinces listening, and we've got the National Department of Health using the information as well. The Minister seems keen. The Ministerial Advisory Committee is from time to time. So people are using the data. It is informing the recommendations from the Ministerial Advisory Committee and from the IMT as well. The DATCOV data is shared in the IMT weekly as well.
Well, that sounds like a useful intervention, implementation of a guideline, particularly directed at diabetics. We in the Johannesburg Health District have been looking at how do we increase the sort of chronic care management of patients, improve that with getting patients delivered their medication at home by community health workers. And one of those that have popped up, partly because they're at risk, but also because good monitoring requires more regular visits, is diabetic patients. So we are kind of in the middle of a intervention where with diabetics, we are trying to get them visited 3 monthly by a team leader nurse to actually do HbA1cs. And then to manage the rest of the condition, assuming that if their HbA1cs can be managed algorithmically by enrolled nurses, that these patients can remain in the community, not needing to come to the facility needlessly, but also get much more intensive care than it seems is happening in the facility itself, where we find many diabetics are coming in with HbA1cs over 10 and who are not even having the HbA1c done, and very poorly managed because they're just rolling from one visit to the next, only collecting medicine. So I think there's a whole challenge to the paradigm right now, which I think is useful to pick up on. So thank you for highlighting those issues. Perhaps let's, in closing, just sorry, go ahead, Waasila.
I was just going to add quickly that the other challenge is we know that there's a high level of undiagnosed chronic disease in South Africa as well. And so there's these people potentially at risk that are not diagnosed. And so we really need to have interventions, aimed at screening and picking up people. And the other data I didn't share is that the diabetics who die in hospital die very quickly after symptom onset. So the Western Cape data showed within 4 or 5 days, people had succumbed. And so I think, the urgency of addressing the risk in diabetics is that there isn't time, and that they deteriorate quite quickly, and that a lot of them we don't know are diabetics. There's many people coming in for the first time diagnosed and coming in DKA. And I just think, there's many risks, but particularly diabetics present a
And I think the obesity as well. I think even though it's anecdotal, I think that subjective. I think that's a useful little bit of information where we think that these community health workers literally need to screen every obese patient, overweight patient for diabetes. And, that's part of the problem with the whole community health worker outreach program. It's not a thorough screening of the community from one end to the other, ensuring that every single person is addressed within a catchment area. It's very much responsive more to the clinic saying, please follow up, this patient's not here. And that's very reactive as opposed to a screening program, which you are suggesting that we go out there and really screen and educate patients about that risk in terms of COVID, diabetic obesity. So that's, I think, useful. Thank you, Waasila. Ahmed still asks a question about testing decreasing despite high positivity rates. I think, again, you might want to defer that, but Ahmed's,
I did think
Ahmed's
that
breaking your brain.
No, I should say that so NICD have observed this, and whether we don't think it's an issue of supply. So there are tests available. There are people to do the test. We think it might be demand. So there are either less people with symptoms who are presenting, or there are people, it's health-seeking behavior. So there are people, maybe one person in the home tests positive, the rest of them develop symptoms and they realize it's likely COVID and they stay at home and they treat themselves without going necessarily for a test. So we think that it's partly, around the demand. But, it could just be that we're reaching a peak, possibly, which the data is showing. And that's why there's less testing.
Yeah, that is true. I mean, we've actually noticed that the number of patients in our, what we call orange area, patients with symptoms of COVID, have actually dropped in the last week or two. And so those who come would tend to be likely more patients with COVID. They're probably more sensitive to it as well. And so coming in. So I think that's probably your answer. I think Vanessa's got a question about the usefulness. I'm not sure that it's a question or statement, but I think you can read it, Waasila, about the usefulness of data translation.
Yes, I wanted to share that we have
workers.
We have presented to an NIOH webinar that talked about risk stratification in the workplace. And so, using this evidence around which people are more at risk, older people at a certain age group and those with certain comorbidities, I think workplaces can make decisions about who they would consider high risk groups and make decisions around the exposure risks. Having said that, looking at the healthcare worker deaths, there have been a number of deaths in healthcare workers over 60 years of age, and I would have thought that they would be people that would be prevented from being in the front line of exposure. So certainly I think there is enough evidence to be able to do some risk stratification in the workplace to be able to ensure that people who are at high risk take more precautions, I guess.
No, true. We're always faced with the problem of how do we deal with our shortage of staff, but within that, we are having to say, who's going to land up getting sick quicker, and so manage that challenge. Let me ask in last question, the data that you have, district hospitals, you've said that you've actually been able to find out which hospitals are actually struggling, and there's some sort of responsiveness where Rudasa said we'll go in and try and help get people better organized. Do you all have data down to that level easily available to anybody in the public domain so that any one of our listeners could perhaps go and see how their hospital fares or hospitals in their vicinity fare in terms of the data you've collected?
We share this with the province every day, and so that's the number of admissions, the number of deaths, and the case fatality ratio. I think we think it might be stigmatizing, or it might be perceived to be stigmatizing to facilities if we share it more publicly and if the media pick up on these things. And also there's always the concern that the data may be lagging. And so, for instance, I know one hospital, they look like they have about a 40% case fatality ratio. When they came on board, they selectively entered all the patients who had died and were catching up with all the previous admissions since March, and so it may skew the perception of their case fatality ratio. So I think we're hesitant to do that because there may be reasons to explain it in some cases. But I think it's still enough to use it as evidence to support some of those hospitals without publicly naming them.
Okay. And I mean, is it shared at a provincial level with any specific set of people, a particular person in, it's just some of this information doesn't filter down, even if it is appropriate for people on the ground. But I'm sure you can actually find ways to share that information, who we might contact to get more detailed information about our particular institutions if we're working within it. I'm asking, and I think the last thing you also shared, and maybe this is your pitch at the end of it, you shared with me when we started talking about the data and the presentation of this data, that not all hospitals are participating, and you were particularly concerned about the lack of hospitals from Gauteng. Do you want to use this as a pitch to say where you're not getting information from, and maybe some of the hitters, amongst us, amongst our audience, might be able to talk to their bosses and say, why aren't you actually putting this information? Reach out to Waasila. She's got the details. Here it is. So do you want to do a pitch on the work you're doing?
Of course, I'll take the opportunity, but
Yeah, please.
Just to share that with Gauteng, we finally reached agreement this week that
Oh, wonderful.
they don't have to have the individual hospitals sharing the data, because they have been collecting the data at a central level and are able to share, to export the data from their database into our database. And so there's an agreement that the data would start sharing today. And so I think we're okay with Gauteng.
Wonderful. I thought we could use the opportunity to hammer them a little bit.
There's the data's not in there, so let's
Yeah,
let's not celebrate too soon. But particularly Mpumalanga and Limpopo have been slow in responding. But now that there's a NHC directive for them to implement, and the minister has requested or instructed all public sector hospitals to implement, I think things are moving really quickly. There's always early adopters. So Free State and Eastern Cape have been fantastic in rolling out. KZN moving as well. I think some of the other provinces we need to support a little bit more to get them on board. But I mean, our system is very responsive, and so it's we can quickly create user access and train, and people can start submitting data like the same day. It's just a willingness, and it's sometimes a willingness at the province to just unlock this. But then it's willing clinicians as well at the hospitals who take this on. And then there are some fair challenges like data capturers that are needed, or connectivity issues and things at some hospitals. But I mean, we've seen hospitals like Tygerberg keep up with 300-400 admissions every day and still continue to submit the data. So I think it's very much about people seeing the value for surveillance and being willing to contribute, because they understand that this is just not submitting data because it's required by someone, but that this is of value to them as well and to their patients.
And it translates back to them. You're giving them reports and access to this information as the users or providers. Waasila, do you want to just provide your slide? I think you had your contact details. Do people contact you if they wish to, whether it's a private hospital or a public hospital, as a clinician on this call, and they want to try and get their particular institution to get into this data provision, they need to reach out to DATCOV19 at nicd.ac.za, and they'll be able to reach out into this, into joining this database collection.
It's as simple as that.
Simple as that. Great. I see there are no more questions. Everybody's very clear about what you've provided us. It's been really insightful. Waasila, I really appreciate you taking off a Friday afternoon to share with all of the people in this webinar. It's going to be taped. If you don't mind emailing me your slides, I will put up the recording as well as the slides onto the sort of post that I've circulated previously, and so it'll be there for anyone else to look at in the later after this. So please feel free to share that link with anyone. I think there's been invaluable information that Waasila has been able to share with us. Waasila, once more, thank you very much. And all those who attended, thank you. Keep well, be safe, enjoy your weekend. Bye-bye.
Bye-bye.